Good morning, everyone. Welcome to the Center for American Progress Action Fund. Thank you for coming out this morning. We will be getting started in just a couple of minutes. Two brief reminders before we begin. First, please silence all cell phones and other electronic devices. Second, there will be a question and answer following the discussion. We ask that you wait for the microphone to come to you, state your name and affiliation before your question. Thank you.
All right, good morning, everyone. Not much going on in healthcare policy these days, is there? My name is Topher Spiro. I'm the Vice President for Health Policy at Center for American Progress, and I have the pleasure today of introducing Congressman Pallone, who has been a leader in protecting the integrity of the Medicare guarantee and of the Medicaid program, making the nation's food system safer, strengthening laws to keep our air and water clean, making healthcare more affordable and accessible, and supporting initiatives that advance and protect the public health. Mr. Pallone is the ranking member of the House Energy and Commerce Committee, which has jurisdiction over issues pertaining to energy, environment, commerce, telecommunications, and healthcare. It's a lot on his plate. From 2006 to 2014, Congressman Pallone served as the top Democrat on the committee's subcommittee on health, and as chairman during the 111th Congress, Mr. Pallone played a key role in authoring and passing the Affordable Care Act. So it's a good time to have him here. Please welcome Congressman Pallone.
Thank you, Topher, and I want to thank the Center for American Progress for hosting us today. I actually have to say a few more things about the center. First of all, right now, obviously, during the healthcare debate and the Republicans' effort to repeal the Affordable Care Act, CAP has really done fantastic work, in my opinion, in educating the public about the negative impacts of the Republican repeal. Not only, and of course, your Twitter is part of that as well. But there's so many things that the center is doing that I think are really being helpful. Because I often felt, I better watch I don't touch the mic, that for most of the time after we passed the ACA, there really wasn't a lot of information going out to the public about the positive effects of it. But in the last 6 months, obviously that's changed dramatically to the point where very few Americans, I think the last time I saw a poll, it was like 15% of Americans. Jonathan, that's about the same level of favorability as our governor, as you know. About 15% of the people view the Republican repeal bills in a favorable light. And I think a lot of that has to do with the center and other organizations that have been out there pointing out the negative impact on the American public and on their health insurance. And also, I mentioned to Topher when I came in, I remember, I think it was in the fall of 2015, when the center put out the report about drug pricing. and the high cost of drugs. And that played a major role, I think, not only in the Democratic platform, but also in Hillary Clinton's comments, and ultimately Trump as well, about how the high price of drugs needs to be addressed, and was a priority mentioned many times during the presidential campaign on both sides of the aisle. The Senator had a lot to do with that as well. I'm going to talk about drug pricing in my comments, but I think after we sit down and Topher starts asking me questions or we have a discussion, we'll talk more about the ACA. But I did want to say that obviously I believe that what Senator McConnell is doing in these last couple weeks, the changes that were initiated by Senator Cruz and others, in my opinion, are just cosmetic. If anything, they make the bill worse than the original Senate bill that was introduced. And most notably, the Cruz provisions that allow health insurance companies, if they enter the marketplace, to also then offer junk plans outside the marketplace that waive the essential benefits package. It was bad enough when the Senate bill said that states could waive the essential benefits package. But now the Cruz amendment and the latest McConnell proposal that incorporates it lets it go even beyond that. So even without the states waiving it, the junk plans could be offered in states, even more states, even those that don't waive them. So I think, again, this is, we'll talk a little more about it. The main thing I wanted to talk about today was drug pricing, so let me get to that. I think some of you know that last week on the floor, we did pass reauthorization of the FDA user fee bills. That was not only for drugs and also for medical devices and generics. That is now going to the Senate. We expect them to take it up fairly quickly, at least that's my hope. And obviously, that bill also, I think, is going to help with generics. Generics, in my opinion, are still a major way to try to deal with drug prices effectively. But the main thing that I want to stress today is that the problem with drug pricing is getting worse, not getting better. So even though Cap talked about this 2 years ago, even though it was part of the presidential campaign on both sides of the aisle, even though President Trump continues to mention it from time to time, Congress and the administration really are not doing anything effectively about it. And we, on our committee, the Democrats on the Energy and Commerce Committee, have repeatedly asked our Republican leadership on the committee to have hearings on the issue. And they haven't said absolutely no, but they haven't done anything. And we're 6 months into the 2-year session, and there still haven't been any hearings. So we're still hoping we will have them. But to me, not only we're not addressing this legislatively, we're not even having hearings on it. We did when we passed the FDA user fee bills in committee, pass a sense of Congress resolution, which was done by voice vote. Jan Schakowsky was the sponsor of it, that said that the committee should address drug pricing. But so far, what sense of Congress are. I mean, they don't have any force of law. So at least they indicated they do care on the Republican side, but we still haven't said any action. But we're still going to push them. So the problem is that not only are higher drug prices, not only the problem with higher drug prices getting worse, not only is it outpacing other increases in healthcare significantly. Next year, annual drug spending is expected to reach more than $500 billion here in the United States. I mean, I could see the point. I don't even know if we're there yet, but I think at some point we'll probably get to the point where drugs are maybe even the majority of your healthcare costs. I don't think we're there yet, but we could easily get there. And so as a result of those high prices, many Americans face real barriers in terms of getting the medication they need, which is why this is such an important issue. And it shouldn't be a partisan issue. We had a poll that Kaiser Family Foundation released just this May that said that 6 in 10 Americans said that lowering the cost of prescription drugs should be a top priority. And that was both Democrats and Republicans. So when you talk about Republican Americans, not the people that are elected or the leadership here, just Republicans in general, they feel it's just as important as Democrats do, which is probably one of the reasons that President Trump and Hillary Clinton talked about it during their campaign. So what can be done? Let me talk about what can be done. And it's complex, right? So some of these things are easy, like talking about negotiated prices, that might sound easy, but a lot of these things are a lot more complex. And I do want to stress that there's no silver bullet. So the reason I'm mentioning a lot of different things is because I don't think one thing alone is going to accomplish the goal or be a solution. So first thing I want to talk about is REMS, or risk evaluation and mitigation strategy. That shows you the bureaucratic aspect of it here. And this is the problem where brand name companies cause delay in bringing generics and biosimilars to market. And that's because they use the REMS to block access for samples of branded drugs. In other words, if the generics or the biosimilars are going to actually come to market, they have to have samples of the brand name drugs. And the REMS program is often used by brand names to prevent that, because they don't provide the samples. Now you might say, is that a big problem? I think it's a big problem. There was a July 2014 study conducted by Matrix Global Advisors that said the ongoing abuse of REMS and REMS-like program costs the U.S. health system $5.4 billion annually. That was in 2014. It's probably a lot more today. So we need to provide a way of reducing the ability of the brand name companies to block generics coming to market by providing access to the samples. And there's actually a bipartisan bill called the Fast Generics Act that was introduced by Peter Welch, and I forget the Republican sponsor, but it is bipartisan. And this establishes an FDA-approved authorization process for generic and biosimilar manufacturers to obtain samples of these branded products. And I'm not going to go into the details unless you want to. That was something that we considered during the FDA markup, but it wasn't passed. We talked about it, but we couldn't get the votes for it. But we need to get the votes for it, obviously, at some point. The other thing deals with exclusivity. Well, this is the second item, deals with exclusivity. I mean, some of this is going to get a little in the weeds here. I'm sorry, but I guess that's why we're at the center. They get into the weeds, right? So exclusivity, of course, we have a process in various ways where brand companies have a period of exclusivity where, they're the only ones that can sell the product because they developed it and they spent money and resources doing that. But the exclusivity protects, certain drug treatments from competition for a set period of time. But today, drug manufacturers often retain that incentive even if they violated criminal or civil law. So one simple thing is to say that if you do that, in other words, if you do something like illegally promote the unapproved use of a drug treatment, you do something illegal, either criminal or civil, then I think they should lose the right to exclusivity for the related products, and basically punishing bad actors if you want. So that's the second thing I wanted to mention. The other thing, a third item, is penalties for misclassification in the Medicaid drug rebate program. You pay a lot, I guess you get a larger rebate, right, if you classify your product as generic. But a lot of times we have situations where drug companies have misclassified their product as generic, and by doing that, they make a lot more money because they get a larger rebate. So the best example of that was EpiPen, right, which was the Mylan product. EpiPen really is a branded drug. However, Mylan had classified the EpiPen as a generic drug for purposes of the Medicaid drug rebate. The change was basically they made more money. So there was a settlement, which a lot of people think was inadequate. As a result, they had to pay back I forget how many millions of dollars. Well, actually, 1.27 billion is what we estimated the cost. I don't know what the settlement was. But what we'd like to see in legislation is stronger penalties so that companies like Mylan have a disincentive to do the wrong thing and to misclassify their product. Fourth item, I already mentioned, in many ways is probably the most significant and the one that you hear about the most, is the Medicare price negotiation. We have price negotiation with the VA, with the military. We don't have it with Medicare. And we should give Medicare the ability to negotiate prices with the drug companies. I mean, that's an easy one. I mean, it's not easy politically, but it's easy to explain. And President Trump, during the course of the campaign and since then, has said that he would like to see that. But the congressional Republicans continue to oppose it. Under Medicare Part D, the secretary the HHS secretary is statutorily restricted by a non-interference clause from having any role in negotiating or setting prices. So the first thing we would have to do is repeal that non-interference clause so that the secretary could do that. And then, of course, there are other aspects of that we can go into, but I don't want to spend too much time. Now, that was Medicare. With regard to Medicaid, what we really need to do there, remember, Medicaid is state and federal match, right, for the most part. And so the federal government, if a state decides that they want to negotiate prices under Medicaid, they can, but there are ways for the federal government to help them do that. And so what we're suggesting is that we create a federal-state Medicaid negotiating pool for high-cost drugs. So under the Medicaid drug rebate program today, drug manufacturers that want to sell their drugs to state Medicaid agencies have to enter into rebate agreements with the secretary, and the states can negotiate additional supplemental rebates. But many states have tried to join together to leverage purchasing power for higher cost drugs, and CMS does not have the authority to facilitate those negotiations between the states and the drug manufacturers. And there's a lot of money that's lost as a result. So what we're suggesting is that we authorize CMS and participating state Medicaid programs to partner with private sector contractors to negotiate supplemental rebates from drug manufacturers. Again, that's we'll call it a Medicaid purchasing pool. That is essentially would require legislation as well. Now, I want to talk a little bit about generics in the Medicare Part D program and the way we can provide greater financial incentives for generics in Medicare Part D. In the FDA user fee legislation, we did incentivize more generic competition. So we did that in the FDA user fee bill. And if you want to talk about more of that, we can. But there are also ways to provide more financial incentives for generics. And there's also the REMS that I mentioned before. So what we're suggesting here is, well, first of all, improvements to the Part D appeals process, because a lot of people are turned down and then they appeal, but they don't know how to go about it. So we have to simplify the process so that seniors or the disabled don't just, abandon hope that they actually can take an appeal. But we also can offer the lowest possible co-payments. Right now, under Medicare Part D, we've been trying to keep the generic co-payments low, and that's saved a lot of money. But it's been much more difficult to do that with the low-income subsidy, the lower-income population. A lot of them, and they're the ones, they're the Medicare beneficiaries that have the highest drug spending. Their co-payment amounts are set by statute. So that means that Part D plans can't lower generic co-payments amounts on their own to encourage the use of generics or lower-cost generics as part of the program. So what we would have to do is, again, need legislation or pass legislation so that we could lower the generic copay, and that would save money for seniors, particularly low income. I mentioned the appeals process as well. So I just want to talk about a couple more Medicare improvements that we can make, and then talk briefly about transparency, and then Topher will go to the questions part. In terms of additional Medicare improvements, one of the things that we can do is close the donut hole sooner. You know that when we did the ACA, we basically closed the Part D donut hole over a period of time, but that hasn't ended yet. I mean, there's still part of the donut hole that needs to be filled. So I would advocate that that we do that 2 years sooner than the current law, and obviously that would help costs for seniors. We could also reduce costs for seniors and for the Medicare program by tying reimbursement in Medicare Part B to the most common dosage of drugs. This doesn't really relate to the opiate problem, but a lot of the debate when we were dealing with opiates last session was the fact that a lot of times people would get a lot of pills, right? And they would basically sit on the shelf, and then other people would use it. Well, that doesn't necessarily relate to this, but what we do see is that drug manufacturers package drugs in vials that contain too much of the drug for most dosage, right? So that increases the cost because you're getting more prescription drugs that you don't actually need. So, and it's billions of dollars, apparently. So what we could do basically is incentivize drug companies to manufacture vials that more closely match the actual need of the population. And again, that could be done by legislation as well. So, and the last thing I want to talk about is transparency and accountability of drug companies and their prices. We have some actual good actors. One of them is actually in my district, Johnson & Johnson, that both Johnson & Johnson and Sanofi have agreed to disclose their drug price increases every year. Sanofi went so far as to announce that they're going to put limits on how much it will increase prices annually. And this is an important first step, but obviously they're doing this voluntarily. They're the only ones that are doing this as far as I know. But for the past 2 years under the Obama administration, the last 2 years of President Obama, they set up a Medicare and Medicaid drug spending dashboards that provided like an online tool where the public could view drug spending and utilization on certain drugs. And it wasn't perfect, but it's obviously an effort to create transparency. And what I would say is that the Trump administration should continue this. As far as I know, they haven't, but they should, because without the dashboards, I think it would even be more difficult to get that kind of information. But also, Congress could take steps through legislation to institute reporting requirements for manufacturers in the Medicaid drug rebate program and in Medicare, that if a manufacturer increases the price of a covered outpatient drug significantly, they basically have to report it. And I would advocate that as an important step legislatively. Obviously, if we're going to deal with drug prices, we have to have the data as to what's actually happening with the increases. Otherwise, it's more difficult for us to address it. And we have this in other parts of the healthcare system, so it's not that unusual to do something like that. So the last thing I wanted to say, and then we'll have Topher come back up here, is that a lot of these initiatives are things that I'm going to work with our committee members, both Democrat and Republican, try to develop comprehensive legislation in the fall that includes the things that I talked about, and potentially others as well. I haven't mentioned everything. I've basically talked to you about ways that I think would be most effective and probably be politically more viable. There are other things out there that may be less effective or maybe even more difficult to do politically, so that's why I haven't mentioned them. But I don't want to suggest that these are the only things. But the main thing is we need to come up with workable solutions to address drug pricing, to incentivize competition, and to encourage the development of affordable drugs. And I think these are some of the steps that we could take in that regard and that we'll work on when we come back in the fall. So, Topher, you want to come up here? What are we doing now? You're going to ask me questions? We're going to have a little dialogue? You're gonna sit
Whoa.
there?
Well, I think I want to say, first of all, that I think it's incredibly important that Democrats have a proactive, positive agenda for reform. We can't just be about opposing Trump care can't just be about Russia. That's not how we're going to win the elections,
I
right?
really talk about Russia.
And
but
so,
whatever.
so we thank you for your initiative and all your work in this area.
Oh, you're welcome. But again, I know it's like the Mutual Admiration Society, but I really think that the center played a major role in this debate with their report that came out a couple of years ago.
Thank
It
you.
really was sort of the start of Washington thinking about this, I think.
One thing that you said that I wanted to ask you about, I found very interesting, was when you were talking about committee hearings for the drug user fee legislation, and we're going to end up having had more committee hearings on that legislation than on Trump Care. And you've been in Congress a long time, right? So
Almost 30 years. I shouldn't even mention it, but I will.
have you ever seen such a slapdash, secretive process in your entire career?
Well, let me say this. It's funny because I don't know what the circumstances were, but in the last couple of weeks, I spoke at one of our Energy and Commerce hearings and markups, and a couple of the Republicans said, "Oh, here comes the regular order guy." They literally called me that. Somebody did. I don't remember who. And that's what I've always been. I mean, I guess I got that from John Dingell, maybe, that regular order, that, we always should have a subcommittee hearing, a subcommittee markup, a full committee hearing, a full committee markup, before we go to rules on the floor. That's regular order, simplified. And it seems like we're getting further and further away from that, to the point where, I guess, in the House, when they did their repeal, they had a full committee markup, nothing in the subcommittee, and I don't think a hearing in the subcommittee. They just went to full committee markup. So they skipped 3 levels of special order. And the only reason I think they did a full committee markup is because I kept, not myself and others on the Democratic side kept screaming about it. But if McConnell didn't even do that, right? He just went right to the floor. So, I mean, this is the problem, is that, I think that a lot of times the Republicans get away from regular order because they don't want people to know what they're doing, right? Because the fewer hearings and markups you have on both sides, I mean, remember, because if you did regular order in the House and the Senate, that could be 6 or 7 opportunities to look at the bill, where if you go right to the floor, there's only 1, if that. So I think that's becoming more common, and I think part of the reason that that the Republicans do it is because it's less opportunity for people to really know what's going on.
Mm-hmm. Yeah. And some people, I think, are under the impression that if the Senate passes this bill, that there's a chance that the House won't pass it.
No, I think that's
And
wishful thinking.
Can you give people a message here about what's going to happen in the House?
I think that's wishful thinking. I think that it's quite clear that the place to stop this bill is in the Senate. And I think the reason for that, in my opinion, is because the senators represent a whole state. What's happened in the House is because of redistricting, you just have so many Republican districts that are so Republican that they're worried more about an attack from the right for not repealing Obamacare than they are about the public in general. Whereas senators, because they represent a whole state, will have a significant number of people who are, progressive or progressive leaning, who will be outspoken and say, don't do this because this is really going to hurt people. So I think that the place to stop this is in the Senate, not the House.
I totally agree. And we're talking broadly here about access to prescription drugs and cost. Can you just talk a little bit about Trump Care and how it affects people's access to prescription drugs? You talked a little bit about essential health benefits, and just want to hear more about how bad Trump Care is.
Well, Topher, let me thank you and the Center again for really pointing out the problems with Trump Care or with the repeal. I don't even like to use Trump Care. You know why? Because it implies that this is a replacement. And I don't think it is a replacement. And the reason I say that is because we paid for the ACA with about $1 trillion in various tax increases, taxes on drug companies, on medical device companies, and some spending cuts. And the Republicans repeal most of it, right? The House is like $800 billion, or almost $900 billion. The Senate is almost $800 billion. So there's no money left to pay for the subsidies for people to buy insurance or to pay for the Medicaid expansion. And so it's not replacement at all. So I'm not being offensive to you, but Trump care implies that Trump cares. And I don't, if he does, maybe he does theoretically, because I don't want to give him bad intentions, but he doesn't understand that this is not a real replacement. But what was your question again? Now I forgot.
How does the repeal affect?
Oh, the essential benefits.
Affect access to prescription drugs.
Yes. The reason that I went on to that is because one of the things that got very little attention until the last 6 months was the essential or guaranteed benefit package. And it was always something that I was very proud of and that I would talk about, because I remember in North Carolina, I always talk this story about in North Carolina before the ACA, they were selling insurance policies for $50 a month that didn't include hospitalization. And I would always say that wasn't health insurance, right? And that's because North Carolina, unlike my state of New Jersey, didn't have to guarantee any benefits. So you could sell junk insurance. Now that's become a focus of a lot of attention now. The New York Times wrote an article about it yesterday in the Sunday paper. But for a long time, nobody knew anything about it. And not to take up a lot of time, but I'll never forget the day when they were supposed to vote for the repeal in the House on the Friday, and they didn't. They postponed it, right? But that day, I remember going to the cloakroom, and I watched both CNN and MSNBC, and there was one of the commentators literally had a wall like this that had the guaranteed essential benefits. And it was the first time that I ever remember any media outlet actually talking about that, which was so significant. But now it's become a major part of the debate. And of course, if you allow what the Senate bill and the House bill, what the Senate bill initially did, what the House bill did when it passed, states to waive the essential benefit package, they could theoretically waive prescription drugs or limit it in a significant way, and you wouldn't have access to those drugs. And now, of course, as I mentioned before, the latest amendments from McConnell, which is based on Cruz's amendment, would basically make it even worse, because it wouldn't even have to be up to the state to waive it. If you offered, Blue Cross Blue Shield offered the policy within the exchange that had the guaranteed benefits, then the Cruz amendment would allow you to sell insurance outside of the exchange and waive the essential benefits package. So you could get somebody not only buying a policy that didn't have hospitalization, but a policy that didn't have prescription drugs. Or even worse, they said, we're covering prescription drugs, but there's a limitation on what they offer. And the problem there is people don't know. People bought that North Carolina policy, thought they were getting hospitalization, and they didn't, because they didn't know.
Yeah, I mean, the only thing I would add is that even putting aside the Cruz amendment and putting aside the essential health benefits,
Right.
when you have tax credits that are intended to buy a plan that only covers 58% of costs, as under the Senate bill, then you're going to have thousands of dollars in out-of-pocket costs, sure, including for prescription drugs, and $6,000 deductibles for people with low income.
Right.
So there are many ways how this is devastating for.
Yeah, because people, remember, under the ACA, even though some of the plans do have what I would consider high deductibles, there are limits on it. And the House bill eliminates, and I think maybe the Senate bill did, as well, eliminates those restrictions effectively.
Yeah.
So they're just going to get higher, and the co-pays are going to get higher, and we don't know whether the cost-sharing subsidies. Even now, the president decides on a month-to-month basis, whether he's going to provide them or not. So it's not good. It's not a good situation.
Well, just since you mentioned that, talk a little bit about the sabotage that's going on, and they're blaming they're selling this bill by pointing to premium increases and insurer withdrawals as if it's the fault of Obamacare.
I mean, there are two things. First, there's the direct sabotage, and then there's the sabotage because it refused to allow us to move and make any changes that would improve Obamacare. And that's ultimately where I hope we go, so I can mention that. But I mean, there's so many forms of sabotage. I mean, the two most obvious are, my understanding is now that, remember, the ACA requires you to have insurance. If you don't, then you pay a penalty through your income tax, right? Well, my understanding is that if people didn't check the box on their IRS form as to indicate whether or not they had health insurance, if they just ignored it, and a lot of people knew that that was the case, then now the Trump administration is not enforcing it. So if you just skipped it and didn't buy health insurance, you won't get a penalty. So once you eliminate the mandate, which of course both the House and Senate bills do, I think the insurance, the marketplace collapses. But they're already trying to sabotage the marketplace by not enforcing the mandate. The other thing is the cost-sharing subsidies. People that get help with tax credits or subsidies that pay for their premiums also get help proportionally to their income to pay for their deductibles and copays. Those are the cost-sharing subsidies. But the Republicans went to court, and there's so many things that damage they did to the AC with the court action. Eliminating the requirements for states to expand Medicaid, which means 5 million people that we thought would have Medicaid do not. But one of the other things they did was to get the courts to rule that to undermine the cost-sharing subsidies, and so basically the courts said that, I don't know if they said it this way, but effectively made it up to the administration to decide when to pay them or if to pay them. And Trump does it on a month-to-month basis. He started out in January saying, I'm not sure I'm going to pay the cost-sharing subsidies. If the Democrats are bad and don't support repeal, then I won't do it. Like a threat, which is incredible to me that the President of the United States would threaten Democrats by saying, I'm going to hurt people. But that's essentially what he did. And, I think the day when they have to decide whether to pay is like around now, maybe the 20th or 25th, the end of each month. And he waits till the last day to decide whether or not he's going to pay the cost-sharing subsidies. So let me give you an example. In New Jersey, the insurance companies, Topher, have to start the process of filing their rate increases or even indicating whether they're going to sell insurance like in June, right? Mm-hmm. And then that's finalized and can be changed between June and November. So Horizon, which is 70% of our market in New Jersey, announced like a 24%, well, they filed with a 24% increase, right? And I asked the president, I said, well, why are you filing with a 24% increase? I can't imagine that health insurance costs have gone out that much. He said, oh, they haven't, Congressman. I said, well, then what is this? So he essentially broke it down and said, well, about 8% of what we filed is for increased costs of health insurance. Mm-hmm. About 10 or 11% is because if the repeal goes through, and there's no mandate, we figure the healthier and wealthier will drop out and it'll cost us that much more. And I don't remember, another 6 or 7% was because Trump decides on a month-to-month basis whether to pay for the cost-sharing subsidies. So I don't know whether they're going to be paid in the next year. So, whatever, all these different things add up to 24% increase for what it would be an 8% increase. And he says, well, if the repeal doesn't go through and the Republicans drop it and, you guys then work together to improve the Affordable Care Act, then by November, we'll get rid of all these other things and it'll be 8%. But right now, it's 24%. So, this sabotage is creating all these problems.
So let's talk about drug pricing and drug costs.
Yeah.
You laid out a number of reforms. And I think there's a tendency on the left or in the progressive community to really focus on Medicare negotiation as the silver bullet. And I think that raises some questions. Number one, if you're really serious about doing that, you have to have some sort of enforcement mechanism, or it's really just words on paper.
I mean, you'd be afraid that even if we gave the secretary that authority, a guy like Price wouldn't actually do it? Is that what you mean?
Well, what
probably wouldn't.
what the economists and experts say, well, that's the issue too, is the current secretary we have. But there's also the issue that even if it were
mandated,
Secretary Burwell, that unless she is given the authority to set a formulary, to in some way back up the threat, either by not covering the drugs or some other way, some other mechanism. We at CAP, we've proposed that there be sort of an arbitration as a backup to give the necessary threat to drug manufacturers that if they don't set a reasonable price through a negotiation, that then there will be a arbitration that is conducted through a nonpartisan, independent entity that evaluates all of the factors. So there's that issue with
well,
Medicare.
That sounds like a good idea to me. That's why CAP, I said that CAP is out front on this, so you're stating that as obviously indicates, how much you've thought about it. Yeah, I think that would be a good idea.
And then just as another example, in the Senate, a bunch of senators have introduced legislation that as a backup would link prices to, I think, to the VA. If the negotiation.
I mean, I think you're going to have to do something like that, particularly if you did it. I mean, I guess, look, if this were to happen and be signed by President Trump, and he obviously supports, negotiated prices, then I guess Price, the secretary, would go along with it since he's in his cabinet. But I would be, I think you do need something like that would be a good idea.
And then the only other issue I want to raise about it is that I think it's not right to think about it as the silver bullet and to put so much emphasis on it, because Medicare negotiation is really just about Medicare.
Right.
And so it's really important to think about this in a holistic manner and to think about how you're going to address these prices as they're paid for through private insurance. And so that's why I thought it was important that you laid out some reforms like the REMS and exclusivity that really get at the problem in the private sector.
No, I agree, and that's why we did mention the other things, and we also mentioned the Medicaid rebate program. And, I did also mention generics because I do worry that because of the media attention to some of these generics that, really have gotten out of line in terms of their pricing, that a lot of the media or even members of Congress think that generics no longer play a role in reducing prices. And I think that's not true. So I want to really emphasize that generics can continue to play a role. And that's why we addressed generics to some extent in our FDA user fee bill, and why I mentioned some other things with regard to generics too, because I do want generics to continue to play a significant role in reducing prices as well.
So I think maybe some people in the audience listening to your remarks and to your proposed reforms might be thinking, this all sounds very good, but we have a Republican president who, although he's talked about prescription drugs a lot, no one can believe a word that comes out of his mouth. There's a Republican Senate and a Republican House. So what is, how do we get this done? What is the strategy here? If we're not talking about a legislative strategy in the short term, like attaching it to some kind of must-pass legislation Is it just about winning elections?
No, I don't want to give you that impression, although I certainly would like to win and have the majority, and we'll do whatever we can
Yeah.
to achieve that. But look, there were many things, not many, there were a few things that President Trump talked about during his campaign that I think myself and other Democrats can agree with. You know, one was high price of prescription drugs. Another was, renewed attention to the negative impacts of trade agreements, not moving on the Trans-Pacific Agreement, renegotiating some of the others. Major infrastructure initiative, $1 trillion infrastructure initiative. Now, granted, a lot of those haven't got much attention, and the president hasn't really moved much on them, well, maybe with the exception of the trade, and we'll see. The jury's still out on that, what he's actually going to do. But I think that there's this notion out there, and I certainly hear it from my colleagues on the Republican side, that we're not doing anything, and that they're going to get blamed for not doing anything. One of the reasons that I think McConnell talked about extending, well, he didn't talk about it, I guess he's actually announced that they're going to meet in August, the Senate, was not just because he wants to repeal the ACA, but also because they haven't done anything. I mean, there's no legislative accomplishments by this Congress or this administration. So I think my feeling is that if we continue to push, and the Senate continues to push, and I continue to push, that at some point they're going to wake up and say, well, wait a minute, I made these commitments as president, I've got to follow through on them. So, with infrastructure, we in our committee put together the Lift America Act and laid down a marker for infrastructure, right? And this would be the same thing. You said, Mr. President, that you want to address this issue, so let's lay down some markers and let's put together some legislation that will tell you what to do and push. So no, I don't think it's just an effort to bring this up in the context of 2018, although we certainly will if it doesn't get done, but to actually see if we can push them to address some of these things. And it was interesting when Jan Schakowsky did the Sense of Congress resolution in the FDA bill. I just thought we'd have to have a vote, and it would be that all the Republicans would vote against it, and all the Democrats would vote for it. And Chairman Walden said, "Oh no, we'll accept that," and it was done by voice vote. So I mean, that to me was an indication they don't want to be on record. They may not want to do much, but they don't want to be on record saying that they're not trying to address drug pricing.
Okay, last question, then we're going to turn it to the audience to ask some questions. Let's say that the Senate repeal bill fails. Do you think that there's any chance of a bipartisan stabilization bill or a bipartisan fix? I saw that 10 of your colleagues came out maybe last week or the week before, including Mr. Welch, with some suggestions. What do you think the prospects are for that, and what do you think should be in it?
Well, that's the whole goal. In other words, my goal would be to have them drop the repeal, either because by August they can't get the votes, or they actually have a vote and can't move forward. I mean, already they've lost 2 who say they won't vote to move the bill forward, and McCain is out for this week. So the goal would be that before they leave in August, that they don't pass the repeal, and that Senator McConnell says it's over, and President Trump says it's over, and then I think we could quickly move towards some kind of improvement that addresses some of the concerns that those Democrats mentioned. I won't necessarily, I don't have all the details of what they suggested, but things like mandating the cost-sharing subsidies are paid, reinsurance to create to provide more carriers, to create more competition in the marketplace. I would like to see, I don't know if they'll ever do this, but I would also like to see some way of mandating or creating even bigger incentive for states to expand Medicaid for those that haven't. I mean, those types of things I think that would be the goal, and I think it's realistic if they drop the repeal and they drop the sabotage. But we're not there yet, as you know. I still think it's very likely that they do the repeal. That's,
Yeah,
I'm afraid, yes. We really got to keep pushing to stop it.
Okay, should we open it up?
Thank you for coming here today, Representative Pallone. My name is Steve Knievel from Public Citizen. Just a quick comment and then a question. So I appreciated, we're in alignment with a lot of the policies that you proposed, and many of them are also included in an existing piece of legislation, the Improving Access to Affordable Prescription Drugs Act. There's about 16 or 20 of your colleagues on it in the House, 16 in the Senate. I'd encourage you to check it out. But relating to exclusivity specifically, there's also a bill in both chambers of Congress that would actually expand exclusivity by 6 months for when an orphan drug gets a new indication. It gets an additional 6 months of exclusivity on all indications, even a blockbuster indication. We think it could cost billions of dollars. I would ask you, what would you say to any of your colleagues that would be thinking about supporting a measure like that?
Well, it's a constant battle, as you know, on my part and others who are progressive, to try to prevent exclusivity from being expanded, right? I mean, there's so many examples. We had the fight with biosimilars, which we kind of lost. We had the fight on orphan drugs. I mean, it's just constant. I mean, pharma constantly wants more exclusivity. And you know, all I can say is whether it's that bill or anything else, I, generally speaking, try to prevent expansion of exclusivity unless there's, you know, some trade-off that is really helpful to the public in terms of pricing or other needs. So I think that's just the constant battle. The companies are always going to want more exclusivity. They're always going to want to fight generics unless they own the generic company, which some of them have purchased. And so you just have to constantly be vigilant and fight it unless it's absolutely necessary.
I'm Phil Posner. I'm with P. Corey and the MS Society. And two of the things that have been a real problem for accessibility have been with the insurance companies, not with pharma themselves. And that one of them is step therapy. And the other one is their random adjustment of formularies not based on any scientific information. And the step therapy is just dangerous, particularly with people with mental health issues, people with things like MS, that you have to try whatever they tell you to try first until it fails. And in some of these mechanisms like MS, it takes 6 or 8 months for them to figure out it has failed, and by then the irreversible damage is done. The random adjustment of the formularies are purely based upon negotiating between the insurance companies and big pharma as to how they get the cheapest price. And so you may be denied a drug you've been on for 10 or 15 years that's working. Suddenly they remove it.
Well, I agree, and I mean, we certainly addressed, I mean, Topher touched on the formulary issue, and, you know, we can certainly look at that as well. I understand what you're talking about. I don't have specific suggestions on how to deal with it, but it's certainly something we should look at in developing the legislation for the fall.
Here's I think the sort of vicious dynamic that's at work here, which is that drug companies skyrocket prices, right? That then creates a pressure on insurance companies to throw up barriers, such as you're talking about. And then that encourages drug companies to jack up prices even more, and it just keeps spiraling out of control. So I think that really at the end of the day, the solution is going to have to involve, in the private sector, it's going to have to involve a deal between the insurance industry and the pharmaceutical industry, whereby pharmaceutical industry agrees to price reasonably, and in exchange, the insurance industry agrees to provide reasonable coverage of those drugs and not throwing up barriers. And that's the kind of negotiation that needs to occur. The problem is we have to set up a dynamic where we force that conversation. And there's nothing that's doing that right now. I mean, I think that was going to happen if Hillary Clinton had won, because there was the gigantic threat of regulatory action. But now there's obviously not that threat anymore. But that's what's going to have to come to pass, I think.
I mean, the one thing, more in a general sense, that I have found, which I think, everybody rags on insurance companies, but, the main thing that I find they want is certainty, right?
Right.
And so, if you can provide certainty, which obviously this administration isn't doing on much related to health care, that's helpful to them. It was kind of interesting to me that in this debate over the essential benefits package and the possibility of selling junk insurance, the New York Times article kind of got into it yesterday, that the insurance companies, for the most part, have been opposed. Everybody thinks the insurance companies want to sell junk insurance. But if you read that article in yesterday's New York Times, you get the impression that that's not true at all. They don't even like what Cruz is proposing. And I think part of the reason for that is they don't like the uncertainty. They want to know what they have to deal with, which is, one of the reasons why, when I mentioned that example with Horizon in New Jersey, I mean, it's obvious to me that Horizon in New Jersey would much prefer to not have the repeal go through, because then they would not have to speculate about what's going to cost them if there's no mandate and if the cost sharing subsidies are not paid.
Yeah, if you haven't read that letter that was released late Friday night from AHIP and Blue Cross Blue Shield, you should, because it was extraordinary. I worked in the Senate for many years. I've never seen anything like that letter in terms of how strong it was, and I think it's what you're saying. They want certainty. They also, I think, want to guard their public reputation. They don't necessarily want to go back to being the evil bad guy. I think that's partly behind it, but it was quite something. One more question. Let's wrap up with one more question. What you pick?
Hi, I'm Michael Cipriano. I'm with the Pink Sheet. Congressman, I have a question about the rest of the user fee process. Obviously, it's supposed to go through the Senate, but the White House issued a statement last week about the House-passed user fee bill, sort of raising issues with the generic exclusivity provisions about the 180 days exclusivity for competitive generic therapies. It was unclear if it was a veto threat or not, but if the president does veto the user fee bill, are you confident that Congress could override a veto if that happens?
Trump doesn't veto anything. He doesn't even know what he's signing. Oh, I have no doubt he'll sign it. He probably won't even know what's in it.
Well, I think you're right.
I'm sorry to be so.
But can you talk about the consequences if it were vetoed, if this bill was not, if this authority was not reauthorized? What would happen in terms of the nation's review of drugs?
I mean, Topher, I just, I'm sorry, but I just, I have no faith that the president would veto anything, to be perfectly honest. And I'm not suggesting he should. I mean, obviously I support the bill, but I just don't see it. I mean, the danger right now is that the reason we're trying to move this quickly,
right.
And there's been some suggestion that some senators that might put holes on it for totally unrelated even to healthcare reasons. How the Senate, you don't give me my, destroyer vessel, and therefore I'll hold up the FDA bill. I'm not saying that that's the case, but I wouldn't be surprised. Yeah. The biggest problem now is with the people that work there. In other words, I think they will actually start sending out pink slips very soon. If they haven't yet, I guess, but they will very soon. And I don't want the workforce to be able, because a lot of what we do in the FDA bill is to try to streamline and make sure that the deadlines are good or even better than they are, to get, the reason we have the user fees is so we get money to the FDA so they can hire people and process drugs and medical devices quicker still being cognizant of safety, of course. So, you don't want the workforce to start getting pink slips because people will leave and nobody will be hired. And then the process of review gets slowed down, which is the last thing I want. So that's the main reason I can't imagine that he would, I didn't read that as a veto threat, I'll be honest with you. I didn't read it that way.
Thank you for coming. Thank you all for coming and thinking just for a moment about something other than repeal. It's good to get my brain thinking about that, other things too. So thank you.